Okay.
This conference will now be recorded.
So I think most of you know that we do record these conferences. Forgot to look how many people listened last time, but we had a couple of weeks ago, we had 10 people, 50 odd people. So I'm getting some feedback from somebody. Paul Frieda. It's Paul Frieda where I can hear my echo coming from. So it is a good practice, even though we are not good at doing it, to mute when you're not talking. And that way, we definitely don't have any feedback. Exceptions are my two co-moderators who I never acknowledge. So it's probably time to acknowledge them. Len, most of you know. Maybe not many of you know that Len's career was as a research pharmacologist. So we are very lucky to have his knowledge, especially when it comes to understanding some of the issues. And Jake, who in future will be known as the voice of God. Are you with us, Jake?
Yes, I am, but please don't be sacrilegious.
Okay.
You can call me the voice in the sky or something like that, but not God.
Okay, I won't do that. The voice from the sky.
Jake, just stop that.
Right.
There's a voice of one of us right here, and that's it.
Okay. The voice from within our midst, we'll call him. From within our midst comes a voice. So I'm going to do the roll call, starting with the voice from within our midst, Jake, Rich Jackson, David Muslin, Paul, Larry, Peter, Dennis C., John, Ross, Les, Nick, Herbert, Jerry, Madhav, Dennis M., and Carl Foreman. Did I miss anybody? Okay. I hear nobody crying out, so we're good. Now, I think I owe John and Paul Frieda slots 1 and 2. I know they have something that they want to raise. They have 2 things they want to raise, but those are people I owe apologies to because last week we did not get to them. And they did have something. So we're going to start off with John and with Paul. And now I'm going to go down the list. Jake, anything you'd like to talk about tonight?
No, thank you, Rick. I'm okay.
Good. Rich, anything for you?
All quiet on the Eastern Front.
All quiet on the Eastern Front. I did hear Rex Waterbury was on here for a moment, and he was referencing that doc of yours who's running the trials. Well, I was writing to him earlier on today. Okay, David Muslin, anything for you?
No, sir.
No, okay. Larry Fish, anything for you?
Nothing today, thank you, Rick.
Okay. Peter Kafka, anything for you?
Yes, I have quite a bit of new information.
Okay. Dennis Correa, anything you'd like to talk about?
Nothing for me, Rick. Thank you.
Okay. Ross, anything you'd like to talk about tonight?
Yes, indeed.
Probably.
Okay.
Which Russ?
No, that was a Ross as opposed to a Russ. There are Russes and there are Rosses. Okay.
Distinction the second time.
You know, it's like when I first got here, this is with great, with apologies, not wishing to insult any of our members who attend from the Chicago area, but I did The first place I went to was to school at the University of Chicago in Hyde Park. And I got, I never did like that Chicago accent. And it's very easy now to tell if somebody is from Chicago. I could do this with David Muslin, but I'm not sure that I don't want to put anybody on the spot. So you ask them to say 3 words. Mary, the name, the lady's name, Mary. Marry, as in to marry somebody. And merry, as in I'm very happy, I'm very merry. So that's Mary, Mary, and marry. And what do they say? Mary, Mary, Mary. That's how the Chicagoans say it. Mary, Mary, Mary. So if I'm getting Ross and Russ mixed up, my apologies. Okay. I don't think I had Russ. I saw you were there, but I didn't write you down, and you didn't say I did. I missed you, Russ. Okay,
Well,
Les, anything for you?
Is that me, Rick?
Les.
Oh, no, thanks.
Okay. And Len, I didn't have your name on here either. What the heck's going on? And nobody said no. Nobody told me. All right.
It could be your weird accent.
Yeah, it could be. Nick, anything? Nick Milano, anything for you?
No, thank you.
Herbert, anything to follow up with for you?
Maybe, but I'll go at the end.
All right.
Just
Well,
want to learn.
we'll decide that. Jerry Pelfrey, how's life in Mexico?
Hot and humid.
Oh.
What else is new? I'm doing
It's
fine.
no different here. It's no different in DC. It's no different in DC.
Oh,
It's hot and humid.
Same
Well,
thing in Connecticut.
at least I get to look at the ocean when it's hot and humid.
There you go.
So I've got that. But the coronavirus is doing to Mexico what it's doing to Arizona and Florida right now.
Uh-huh.
Anyway, Rick, I don't need anything. Thank you.
Okay. Madhav, anything for you today?
Yeah, I do have an update. I spoke to the doctor and he's
Great.
given me a line of action. And
Okay.
a lot of inputs that you guys gave me last time really drove right home. I appreciate that. So I'll need some advice. So I'll give you an update and ask for some
That's
advice.
great. We will come to you. My buddy from Chicago, Mr. McGuire, anything for you?
Hey, Rick.
Hi.
No, nothing new. I may be in and out on this call. I'm puppy sitting for my son's puppy.
Okay, that's all right.
So you might get a cameo. You might get a cameo appearance from a 50-pound puppy.
Oh wow. Okay, we love that. We love having pets in the. There are certain calls where the pets rule. Not on this one, but there are some calls where pets rule. Carl, anything for you?
No, thank you.
And Russ, anything for you?
Only if we get extremely bored.
Okay, and Len, anything for you?
No, sir. Thank you.
Now, I know that if Rex comes back, and he was here for a moment, he has something, so I will work Rex in as best as I can. Okay, so we're going to start with John, and then we're going to go to Paul. So, John, you can raise the issue that we talked about, and anything else.
You're going to be sorry you asked, because I got 3 today.
Okay.
So first one is, this is probably a good one for Russ with a U, but I need a Med Onc referral for my brother at Dana Farber.
Okay. For prostate cancer?
Yep.
And what sort of level of prostate cancer are we talking? Does he needs a Med Onc?
I think he needs a Med Onc consultation. He's been followed by his radiation oncologist for several years. He had radiation 3 years ago. His PSA has come down and is now hovering around the 8 level. And he's just getting kind of nervous because it's not going any lower. And his radiation oncologist says, we're fine. We'll test another one in 6 months. And I think he'd like a little reassurance that he's fine to go without any further treatment right now.
Yeah, well, 8 sounds a little high if he's only had radiation. Well, you know, we very much like Chris Sweeney. I'm going to let Russ respond as well. We very much like Chris Sweeney. And then there's a lady, what's her name? And one of our guys just went to her. I've got to think who it was, and was also quite happy with her.
Dr. Kilbridge.
Thank you, Kilbridge. Thank you, Nick. Thank you. Yes, it was Nick that went to Dr. Kilbridge. So that's another name that's recent. There are a couple of people that I'm not thrilled about. And we've had people who haven't been thrilled. Mary Ellen Taplin, very, very smart, but people don't love her bedside manner as much. Ellie Van Allen is great, but he doesn't really see patients. I mean, he's the best, but it's hard to get him to see. It's, you know, he doesn't have a very large clinical practice. He's mostly a research doc. Russ, are there any other names you would throw into the hat? Where's Russ?
Maybe he stepped out.
Maybe he did step out.
I'll get him at the end because I know he likes his doc, whoever it is.
Yeah, well, Russ sees a guy, Russ saw Sweeney, but he sees somebody else as well who works for Sweeney, who he quite likes.
Oh, okay.
Here he is. Russ, where were you? Turn on your mic.
I went down to get a chocolate chip cookie. Don't judge me.
You got to share.
Okay. Who do you like as a Med Onc for John's brother?
From Dana Farber?
Yeah.
Roberts, Dr. Roberts.
Is he down in
Sweeney? He's Sweeney's protege.
Okay, so there you go. It might be easier to get.
He's been phenomenal.
Okay, great. I've got to add him to my list.
Thank you.
Okay. So there you go, Kilbridge, Roberts, or Sweeney. Sometimes it's hard
who is it that's up here?
It's for John.
Okay.
For his brother. For his brother, not for him. Is Roberts is in Boston?
Correct. He's Dana Farber, Boston, Brigham's and Women's Hospital.
Okay.
Okay. All right. Next question, Mr. A.
The next ones are timing questions. I've heard a lot from the guys about the timing of when side effects come on after Lupron, but I would like to know what the timing is for Degarelix, because I just had my first shot today.
Mm-hmm. I have to turn that to a Degarelix Firmagon person because I can only speak about Lupron. Yes, Herb.
I mean, the only negative side effect I had with Degarelix was I still have a couple of scars where they stuck in this huge needle. Testosterone went down right away. I mean, it really took a nosedive. And Degarelix is a
fast.
whole lot better to start with than Lupron because you don't get that surge.
Yeah.
You don't get any hormone surge. And so I personally just took it. The immediate effects were really kind of nothing. Obviously, the later effects I don't enjoy, which is this weight gain and sort of slowing metabolism. But that's not, I mean, you'll get that with Lupron or anything that takes away your testosterone is going to do the same thing.
Yeah, okay.
So are you feeling anything specific? I mean, yeah, there was a little bit of pain on the injection.
I
'cause it
just
is
thought
kind of a
maybe the
heavy-duty-
timing would be, I just thought maybe the timing would be different and it wouldn't come on so slowly as with Lupron because of Degarelix being so much faster.
Right, well, the timing of the major effect, yes, it really knocks down testosterone fast.
Yeah. Okay.
Anybody else on that? Anybody else have experience with how quickly they felt the side effects when they first got Firmagon? Len?
Yeah, Rick, I had, it was quite a few years ago, but when I first started taking Firmagon, I think it took about between 2 and 3 weeks before I started feeling any of the typical side effects like hot flashes or fatigue, things like that. But the worst part that was all fairly mild. The worst part for me were the injection site reactions. So if you're not getting much in the way of injection site reactions, count yourself very lucky.
Oh, thanks for sending that article, Len.
Yes, that's right. Yeah, I did send that.
I gave it to the nurse and so she wouldn't get mad at me. I said that the guys made me do it.
Good. Good for you. Did she
I'm
read
only-
it?
Yeah. Well, she skimmed it in the office and said she'd read it and kept it. She said,
Okay.
"Oh, this is 5 years old. I'm more up to date than that," she said.
Same drug it was 5 years ago.
It's exactly the same drug. But I mean, so far, I'm only about, I don't know, 5 hours out from the injection and it's sore, but not terrible yet.
You could get some additional swelling and pain, but like I said, you might be lucky. And like Herb, I think you said you didn't get much of a injection site reaction. Is that right?
Nothing really acute. I mean, yeah, I mean, it was an injection. I knew that it was there. It's a big depot. So you kind of feel that lump.
Yeah.
But I didn't find it, I mean, I did not find pain. There wasn't a lot of pain
Oh, great.
associated with that.
Okay. All right.
But I think I think with something like that, it depends on a lot of technique of the person who does the injection.
That's
And
what
where they put
Len's
it.
article said. Yeah.
And how much stomach fat you have. I mean, when I got mine, I had no fat. So
Yeah.
that was a problem.
Well, after the 10-pound COVID, I had no problem with that. The nurse also said to tell Len that she has her own little strategy where she picks up the subcutaneous tissue and holds it firmly for 20 or 30 seconds after the needle is withdrawn. And she thinks that helps to seal the medicine from tracking back to the dermis.
Yeah, that's logical. Mm-hmm.
Yeah. So the third one I had a question is about abiraterone, which is going to be added, and my question is about the timing. The first guy I saw said he'd wait until radiation was all done, and that's I still have another month to wait to start it, and that would start me on abiraterone after radiation, maybe 3 months from now. But Dr. Petrolak didn't give me an exact date, but he seems to be ready to go kind of right away. Is there a timing for that drug?
Well, I think as long as you're on the Degarelix, you should be on hormone therapy while you're getting radiation because they act synergistically.
Yeah, I will.
I'm not sure you need to be on abiraterone right away.
Is there a reason to wait?
Well,
until after, was he just
the
trying
newer-
to save your side effects?
The newer thinking is to start the, you're a Gleason 9, right?
Right.
So the newer thinking is that you start the second line anti-androgens early, right up front.
Yeah. Okay. I'm probably about 14 weeks, 15 weeks after my surgery, so that's up front now, isn't it?
Yeah.
Yeah.
Okay, done. Thank you.
Anyone else have anything on when to start the abiraterone? Anyone else have any thoughts on that?
I can share my experience when I went through it last year, John. I was operated in February. I went on to Lupron only afterwards because they had thought it was still within. But they gave me Lupron with apalutamide immediately. My testosterone didn't go down to 0. So in July, so that's another 2 months, they added Zytiga abiraterone. So, and that's the one that really brought the testosterone all the way down to negligible.
Oh, they waited until they weren't satisfied with the drop in your testosterone and then added it.
That's right. So he wasn't satisfied because I was still in the 40s in my testosterone, and this was with an apalutamide was started at the same time as Lupron.
Why was
Those two
that?
came concurrently.
Why did apalutamide start right away?
See, I was trying to get into the clinical trial, the Formula 509, which was two enhanced ADTs in addition to Lupron. So it was Lupron plus, apalutamide and Zytiga. Then I didn't get on the trial, so he started me off with apalutamide. When it wasn't adequate, he raised it up to abiraterone as well. So then I took both of them concurrently for 6 months.
Oh, I see. Okay, I got the feeling that the androgen blockers for me are kind of off in the future somewhere, although I remember you guys a couple of weeks ago talking very fondly about darolutamide and its lack of side effects.
Yeah, well, I think the point here is that most people will start with just one, and it could be darolutamide, it could be apalutamide, it could be abiraterone, it could be enzalutamide, but I think what to take out of Madhav's experience was that they started both of them very quickly at the same time. They could have just as easily, if the ARN 509 was not on the table, they could just as well have started him on abiraterone and the Lupron.
I see.
So I think it confirms what Len is saying, which is the thinking now is to start you on 2 early, and the old thinking was to wait a little bit.
Yeah.
You may experience more fatigue that way, but it's probably not a bad idea.
And I'm not missing out on anything by not starting a blocker at this time because I've already got the other 2. I think that's what you're saying.
Well, yeah, I mean, the blocker is usually an alternative to the abiraterone.
Yeah.
And some people will start a blocker first and then the abiraterone, and some people will start the abiraterone first and then the blocker. What the research suggests is you don't get a huge amount from the second one when you start the first one. Now, about 3 years ago, Len will maybe remember this better than I do, there were 2 or 3 studies on the sequencing. And I think the result of those studies was that it was better to do the abiraterone before the androgen blocker.
Mm-hmm. Okay, fine, good.
Go ahead, Herb.
Current results.
Yeah.
That's the current thinking.
Right.
That if you're gonna have to switch from one to the other, you're better off doing the abiraterone first, then moving to enzalutamide. But based on this stuff that this phase 2 trial that I saw, that may not be the best strategy right now either.
Okay. All right. Well, I think we've answered your questions,
Yes, thanks, guys.
and I think it's time for Paul Frieda, so he doesn't take umbrage with me again. Mr. Frieda, how are you?
Yeah, this is Paul. I'm good tonight. I don't need any time.
Well, wait a minute. You had a question last time. You can raise your question with the guys.
No, you sort of answered it when you evaluated my my bone density report.
Well, I think it's a. I asked you to raise it only because I think it's good that we maybe talk a little bit about bone density because we don't often talk about it. So feel free to just raise the issue, and I'll respond, and we'll see if anybody else has any thoughts on bone density.
Well, what I had trouble reading the report, it talked about a Z value and a T value, and they had to do with standard deviations. And then they talked about with reference to your average age group versus everyone. So I have had a difficult time interpreting it. And so, right. But your evaluation answered all my questions. So anyway, the report gives you a number which represents the number of standard deviations away from the mean, and right. And then there are three categories: you're okay, or you have osteopenia, or you have osteoporosis. And right. I thought I had osteopenia, but you said I didn't.
Right. So
is that right, Rick? I didn't have osteopenia, right?
Right, as I recall. I mean, you had phenomenal bone density. I can't exactly remember your numbers. I don't have them in front of me. Let me see if I can pull them up. I think I was so impressed with those numbers, Paul. I put them in my notes because most people.
Yeah, you said they were very good.
Yeah. Yes, I did. So Paul had positive 2.3 in his spine, and you're 73, Paul? 72?
I'm 73.
73. So just for comparison, I was minus 2.4 in my spine at age 56, I think, when I was diagnosed. So the T-score is the standard deviation from the norm for a 35-year-old. And whilst it doesn't make a lot of sense in terms of for many of us, because we are nowhere near 35, it is the standard that is used to determine whether you need treatment or you don't need treatment. And for example, somebody came back to me this week, one of our regulars, and he was borderline osteoporotic, just like I was, and he was minus 2.4, and they were just going to give him a Fosamax pill, which I don't get. I know that in my own case, because they knew I was going to be on long-term hormone therapy, they gave me 3 infusions of Zometa over a period of 2 years, and it worked. So the T-score and I forget the Z-score. I'd have to go look it up again. Maybe somebody else on the call remembers what the Z-score stands for. But the bottom line here is not so much what the T and the Z are, but it's that you must get your bone density tested if you're on long-term hormone therapy. It is so important, and many doctors just don't do it. They forget all about it. It's a very simple, easy test. You lie on a table, a scanner goes over you. Paul asked me, well, what about the rest of the body? They only gave me a score for my hips and my spine. I don't know why they do it, but that's what they do. That's the 2 spots that they usually measure from. And if you have weakness in your bones in either of those 2 spots, that's the trigger to start you on some sort of a bone strengthener. But men, just like women, do lose bone density over age, and then there are some people like myself who have issues in their genes and their family history, and they need it much younger. And then the other thing you have to do is you have to change your exercise regime to try and stress those joints where those bones that are weaker. So anybody else want to say anything about bone density? I just really wanted Paul to bring it up because I wanted to give everybody a little pep talk on bone density.
I got a question about that. Do you get that scan after you've been on your hormone therapy for 6 months or a year, or at a baseline at the start?
Yeah, they're supposed to do a baseline at the start if they know you're going to be on it for over 12 months. That's what they're supposed to do.
Right. Well, I mean, I think obviously I had one at the beginning, and I was osteopenic. And so I talked to one of my buddies who's a rheumatologist, and he said, almost everybody our age is osteopenic. So he wasn't that worried. It was not osteoporotic, but nevertheless, I'm on all the therapies, calcium and Somadex, and
Right.
making sure that it doesn't get any worse. And the thing is, I was shocked because I'm a runner.
Yeah.
Right. I really thought that I had it beat.
Yeah.
That I have been exercising for the last 50 years. And so, but I think aging is what really takes over after a while.
Well, I mean, I think some of it's aging and some of it is I've always had very high serum calcium. And I think that in my own case, I think that my calcium leaches into my blood. And so I'm always short of calcium. Maybe it's because maybe my acid alkali mix is wrong. I don't know the reason, but then I think about my dad, God rest his soul, and he must have lost 5 inches of height. I mean, when he was my age, he was my height, not even smaller, and he was over 6 foot as a younger man. So, it's family issues. Anybody else have any questions about, if you haven't had a bone density test and you've been on hormone therapy for a period of time, please get one. Please ask your docs to give you a bone density test to measure your bone strength. This is different from a bone scan. It's a completely different test. It's called a DEXA scan.
You can get it every 2 years.
Yep.
Rick, I don't know why, but I asked Dr. H about it after we talked about it here, and she said, wait a year. Wait till you're on for a year. No good.
Yeah, that's great. Because if you're like I am and you're minus 2.3 when they put you on, why don't you wait and let it get to minus 2.8? Huh? I mean, hello.
Right.
I mean, that makes me mad.
I would not. Wouldn't wait. I mean, if you're on hormone therapy, it's inevitable that this is going to happen. So why not put yourself in a situation so you either know you need supplementation or you don't? And I think most of us would need it, even if you just take calcium.
Right. I don't see the sense. We know that hormone therapy is hard on the bones. But when you don't have testosterone in your body, it can make your bones significantly weaker. Not everybody. Look at Paul. I mean, Paul's got phenomenal bone strength, but that's what it can do. So it's better off to know at the beginning, because there are some few people, like Herb is one. Herb was older than I was when he found out, or me, I was a young man. At 2 point, I was osteoporotic. As a baseline, I didn't even know. I would never have known. Had I not gotten prostate cancer, I might never have gone. And then, your bones get weaker and weaker. So I urge you all, don't let your doc put it off. Go ask you can ask your PCP. They'll order it for you.
Rick?
Yes, sir.
I listened into a Zoom session last week, with the US2 group in Manhattan, and they had a speaker, Dr. Lauren Fishman. I don't know if anybody's heard of him. And he's an MD, but he's retired from that, and he's promoting yoga as a means for bone strength, preventing osteopenia, osteoporosis. And he claims he did some studies that showed it was actually superior to the bisphosphonates, things like Fosamax. If anybody wants to check it out, his website is sciatica.org. I'll put it in the chat box. That's it.
Excellent. Thank you. Yeah, listen, try it. But whatever it is, do something. And if you don't know, you don't do anything. So, I mean, when I say that, we all know that that we've got to do our resistance work if we're on hormone therapies. But I mean, it's much more urgent if you have an issue. And I don't see why you would wait to find out if you have an issue or not. That's just my approach. I got tested every year when I was on hormone therapy. Once they figured out that I was borderline osteoporotic, I got tested every year. All right, let's keep that. Paul, thank you for serving as the straw man there.
Okay.
Rick, you have a couple new callers, Sylvester, Doug Matthew, Bob, and I think, is that you on the telephone, Doug?
Yes, Doug's on the telephone. That's great. Okay, and Bob, are you new to the call or not?
Yeah, I don't know if you can pick me up or not. Can you?
Yes, we can.
Okay, I don't know why the picture doesn't show up, but I see you guys. Yeah, first time here, had a struggle getting in, but now I'm here. I kind of wonder, when is the time you decide to give up on your meds? I've gone through a cycle so damn fast from January a year ago, finding my prostate cancer returned, because these wonders of medicine never told me, after I had a radical prostatectomy in 2007, that 30% of the time your prostate cancer will return. I had no idea that was the case. And I find out it is in fact true, and they were not taking my PSA readings. I ended up discovering I had a recurrence of prostate cancer because I had bowel problems and went to have a colonoscopy. They discovered a tumor in the rectum, and it's been all downhill ever since. PSA at that point was discovered at 85.
Okay, Bob, let me stop you just for a second, okay? As it so happens, we do like to give new men a priority, and so we will spend a little bit of time with you. We've got a bunch of guys who have questions, but maybe we can just take 10 or 15 minutes. If you can start your story at the beginning, run through it quickly, and then we can talk to you about what we suggest. So
I will go quicker than that. I've been reading by Health Unleashed, which is a site you guys probably all know about.
Health
Unlocked or Unleashed, whichever. They have some very bright guys on there. Anyway, I have gone from, I even took some notes on it. Xtandi, Xgeva, Eligard for shots, then Firmagon, and then I've gone to Casadex.
Hold on a minute. I want you to stop. Listen to me, okay? I want you to first of all tell us how old you are, when you were first diagnosed, and then tell us, take us through this chronologically, all right?
Okay, trying to take less time. I'm 80 years old.
Okay.
I was diagnosed with prostate cancer in 2006, I believe,
Okay.
and had a radical prostatectomy and
Okay.
assumed I was home free. In 2019, I referred myself for a colonoscopy, discovered I have a recurrence of the prostate cancer. By now, it's in my bones from my pelvis all the way up to my neck. I don't know where all else. And I'm weak as can be, like a dish rag. I've gone through a whole gamut of treatments, including Exgeva shots for bones, B12 shots. They replaced that with Firmagon at one time, but injected it poorly, and I ended up in the hospital. So I'm back on Eligard. I was put on Cacidex in January of 2019. I guess I told you I'm 80 years old, so I probably bought the farm anyhow, but still trying at this point to hang in there. They changed me to Zytiga, and then I found there was a generic form, so I went to abiraterone. And a few months later, they said that's not working, so we went to Xtandi. And then a couple months ago, they decided that's not work and have me put on Linpara. And I've been told that's pretty much the end of the line for ordinary pills. And the next trick would be some chemotherapy. I don't know what exactly that would be. So anyway, my symptoms at this point are just getting duller by the week, weaker all the time, sleep about 16 to 18 hours a day, try to get something done for 15 or 20 minutes and I'm back in bed. Can't walk more than a couple hundred yards or so. And I feel like, well, between all the problems, chronic glaucoma since I was 30, and also the real complication is heart problems. I had open heart surgery in 2015. Replaced the aortic valve. There was a patient mismatch, so they didn't put in quite the right size valve, and apparently that's been causing me problems ever since. So between labile high blood pressure, labile hypertension, and a heart that could be pooping out on me any time, and all these attempts at stifling the cancer, I kind of feel like maybe I'm just at the end of the rope, and maybe one's just better off to say, hell with all these medicines and let it go and see what's going to happen. I feel like somehow the combination of meds and cancer and heart problems is going to do me in anyway. Any comments about that?
Yeah. So where do you live, Bob?
Now we just moved to Tallahassee, Florida, so now I got a whole new cadre of doctors.
Okay. And where were you before? Where were you treated?
We were in Naples, Florida. I did make one sojourn to the Mayo Clinic in Jacksonville last November, and got some help, but not a whole lot.
So you were in Naples. Where were you being treated? Was it by Florida Oncology?
Yeah, Florida Cancer Specialists, they call themselves.
Florida Cancer Specialists, right? And yeah, we actually have some experience with that office. So have you ever had a specialized prostate cancer medical oncologist, or have they always been general medical oncologists?
Well, I'm not sure what that specialized guy would be, but I think they're general.
Right.
The closest to that was a visit with Dr. Tan at Mayo, and he was not too optimistic.
Okay, so the specialized guy is a guy called a genitourinary medical oncologist. Somebody will put that in the chat window for you. And they are doctors that specialize in prostate cancer. Since Len has a house in Venice and spends half the year there, he is familiar with the docs down there, not in Tallahassee, though. I know that he found finally a very good medical oncologist down there. But my concern is that for somebody in your situation, the standard of care would have been to give you chemotherapy immediately and to wait on these drugs. I have one other question, and then I'm going to throw it open and we'll see what ideas we come up. They put you on Lynparza. Do you know why they put you on Lynparza? Did you do a genomic sequencing? Did they test your tumor to see if you had mutations?
I did have a test and they show I have the BRCA2 gene.
Okay. And how long ago was that?
The test was, I don't know, 4 or 5 months ago. And then eventually I was put on
Lynparza. No, yeah, I mean,
Lynparza.
yeah, they should have stuck you on Lynparza right away as soon as they saw it. Let me first go to Carl Foreman. And Carl, maybe you can tell Bob about your success with Lynparza.
Sure. I've been on Lynparza for, boy, it's like that. It might be coming up to a year and a half now. But the immediate results were that it did have a very favorable reduction in my PSA. And within 2 months of being on it, it went to undetectable and has stayed undetectable up until around now, which is about 15 months. And I was also, I am also BRCA2 positive as well.
Thank you, Carl. Bob, what was your Gleason score after your RP?
After my RP, I have no idea. Before, I think it was a 7.
4 plus 3 or 3 plus 4?
I couldn't tell you.
Okay, well, you need to go back and get from your doctor that post-pathology. And you need to know and should know what your Gleason score was, whether you turned out that you were a 4, whether you were a 5 or an 8 or a 9. It's the post-pathology that's definitive. They slice up the prostate and they look at it again. And what is your current PSA?
It was gone up from like 3.5 to about 15. I think it's back up to about 30 in the last 2 or 3 months.
Okay. And how long have you been in the
Lynparza? Let's see, I think just one batch, just 30 days.
Okay. So, Len, thoughts?
Yeah, so when they determined you were BRCA2 positive, was it a blood test or a biopsy?
It was a blood test sent off to some fancy lab somewhere.
Oh, okay. So you are germline positive. So yeah, absolutely. Lynparza is the right drug for you, and hopefully you'll have the kind of success Carl had. I would, give that a few months and see how you do there. I'm pretty confident you'll do better, at least on that drug, than you have on anything else.
What are the signs that you're doing better? So far, I haven't noticed any.
Yeah, I think you'll do well. Chemotherapy at your age and with a heart condition, I don't think that's a good idea personally. And you're going to feel pretty crappy for sure. You're already feeling very weak, sleeping away most of the day. I don't think chemotherapy should even be entertained by you. But so fortunately, I don't think you'll have to consider it because the Lynparza should do very well with you.
Are you having particular side effects from it?
Yeah, the typical side effects are weakness. I'm sorry to say, maybe some loss of appetite. It depresses your bone marrow.
Cognitive impairment.
Well, that
got all the above.
That could be from the ADT drugs that you're on, Carl. You're still on Lupron, right?
Yeah, well, Eligard, yes.
Eligard, okay. So I've never heard of Lynparza causing cognitive deficit. Have you, Rick?
No, I mean, I think that the cognitive deficit is largely the ADT, Carl. I did want to say though that he's not necessarily germline, because we don't know. He could have had a liquid biopsy. He could have.
Oh.
They could have done a liquid biopsy. If it was a spit test, Bob, was it a spit test or did they take your blood and send it away?
Blood sample.
Right. So we don't know. The difference here is that we're trying to determine if you inherited this BRCA or if you made it yourself in your own body. And the importance of that is not so much how the drug works, because we don't think it makes any difference whether you're somatic or whether you inherited it. It does matter for your family.
Yeah.
So if your BRCA is inherited, then it makes a big difference for the family. Do you have any other cancer in your family?
We've had some, my mother's line, and we have 2 grown children, and I warned them about checking out whether they have the BRCA2.
Okay, so again, if you, do you know who they sent the blood to? Was it Foundation Medicine or Caris?
I thought it was California somewhere, but I don't remember the name of outfit.
Okay.
Does that matter much?
Well, we're just trying to figure out the type of BRCA, and one easy way to figure it out is to go get a color test, which is just a spit test to color.com, and if it comes back with BRCA, we know that it's inherited. If it doesn't come back with BRCA, it's not inherited. So if it comes back positive, then your kids can get the test for $50. It costs you $249, I think, to do that test. But again, it's something you should be talking to with your doctor. I mean, I just had this situation with somebody else who's on this call right now with a different mutation, and we don't know if that mutation is germline or somatic. And it's important to know, not so much for changing your treatment, but it's important to know for your offspring.
Okay, well, thank you.
What sort of doctor are you seeing right now? A medical oncologist?
Yeah, Dr. Tetro, been in oncology for, I don't know, 15, 20 years, and seems fairly up on things, but how do I ever know?
Well, what we recommend, to be honest, is that you get a genitourinary medical oncologist on your team. You need a GP Med Onc on your team. In your case, probably we would suggest you go to MD Anderson in Houston from Tallahassee. And we would recommend somebody there, because they're the guys that really know what they're doing. At the same time, you may want to wait and see if you get a response from the from the Lynparza, the olaparib. See how you do with that to begin with. The trials suggest that men with BRCA2 do respond very well, but it takes, it's going to take some time. Carl, how long did you say it took you before you started to see a drop in your PSA?
Well, I started to see a drop in the first month, but it went to undetectable in about the 3rd month.
Okay.
Wow. Well.
All right. So, Bob, we suggest that. How did you find us, by the way?
Oh man, I was snooping around on the internet today. I forget exactly how it popped up. What about Moffitt Cancer Center in Tampa compared to MD?
Yeah, Moffitt's very good too. I think we have a couple of names at Moffitt. Anybody can help me with names at Moffitt right now? I know there's an Indian guy there. I'd have to look him up. But to be honest, if it was even up between Moffitt and MD Anderson, I take MD Anderson in a heartbeat.
Uh-huh. And you don't think the guys at Mayo, and I went there partly because, well, it's closer, but I thought they would have heart guys as well as cancer guys, more so than most of these other places. So that's why I went to Mayo in Jacksonville.
No, I mean, if it were me, I would be going to MD Anderson. And if I didn't, then my second choice would be Moffitt.
Uh-huh.
And then maybe, I mean, first of all, you know, there are issues with these remote centers. They're not as good as going to, say, Rochester. We've got guys on this call who go to Mayo in Phoenix, and they're happy with their docs. Some are, some aren't. But I think if you got the opportunity to go to MD Anderson, I would go because they are outstanding. And then I would back that up by going to Moffitt, and we can get you names at Moffitt if you need names at Moffitt.
Okay. Well, do you think at 80, with the history I discussed, there's a very positive kind of outcome and predictable anyway?
Well, I mean, I think you heard from Carl Foreman that he had a very good response to the olaparib. Mm-hmm. So, you know, that's firsthand with somebody who had also metastatic disease and has responded really well.
And Gleason 10.
And he was a Gleason 10. There you go. So, you know, the answer is, yeah, that you may well respond.
I thought he was talking about Lynparza.
That's the same drug. Lynparza is the commercial name for olaparib.
Oh, okay.
Okay.
And it was recently approved by the FDA, so it should be much easier for him to obtain it.
Yeah.
At this point.
Yeah. Yeah. I mean, there should be no. Well, you're on it already, so it should be fine. All right. Anybody else on the call want to say anything to Bob?
Well, I thank you and I appreciate the input.
Keep in touch with us, Bob. We'd like to know how you make out with the Lynparza.
Okay.
Yeah, also, just for me, I have 2 daughters, and both of them were tested, and both of them are also positive for BRCA2.
Wow. Okay.
Okay, Bob, listen, we did a webinar about 3 weeks ago called The Talk for prostate cancer, and you might want to listen to that. Carl was on it with his daughter. You might find it very helpful to listen to. It was moderated by an excellent medical oncologist, GU medical oncologist, and it's really worthwhile. If you go to the blog on our website, you'll find it. The other thing is, please sign up for our reminders, or you can send us an email and we'll put you on the list. That way you'll get an advance notice. You can send an email to info, I-N-F-O, at ancan.org.
Yep, thanks. I did that already. Yep.
You did, okay. All right. Well, then we'll make sure if you've done that, then we'll get you on that list, and we'll hope to talk to you, and we'll continue to support you.
Okay, thank you much.
Thank you. All right, guys. So I am going to Peter. Peter, what's up?
Hang on a second here. Let me get my camera on again. Yeah, I don't have a lot of time because I promised my son I'd do some plumbing job with him in his mental house. So fixing a shower. So I'll try to go through this quickly. Yeah, I got a fair amount of new information here. One is a week ago I did I'm off of chemo now. I did my last round 3 weeks. It'll be 3 weeks on Thursday since my last round. I've still got some lingering side effects, which I'll talk about in a second. But I did a CT scan. here, which is the only thing I can do here, considering the circumstances and the inability to travel and so forth. And the results came back in an encouraging way. Nothing, here I am 6 years later, I still don't have any evidence of bone metastasis. This is the first CT scan, official one I've had since my original diagnosis, and it didn't pick up any bone mets at that time, and I still don't have any bone mets. It did pick up a little bit of lymph node action, which I kind of knew about. Nothing huge or out of the ordinary, and it still picked up the peritoneal implants there. Although it said they were I don't know. I can't remember the exact wording for it, but they're still small. But then I started thinking, well, chemo can kill things, and it can take months for the dead cells to get out of your system. So it might have picked up, dead cancer cells in my peritoneal at this point. It's hard to say what it picked up. So generally, I felt pretty positive about the results. I didn't talk to my local oncologist. I meet with him a week from Wednesday. And I haven't talked to Dr. Turner yet about it. I think he was on vacation, but I'll try to catch him. So that's one piece of news. Second piece of news I picked up today at the mailbox. That was I got my report from Caregivers from the biopsy that was sent from the peritoneal implants that tested the prostate cancer, which is why I went to chemo to begin with 5 months ago. And lo and behold, the Caris report came back MSI high this time, which was a big question I had, because before medicine for my original tumor 5 years ago, it was MSI stable. And this is the first indication that it has changed to MSI high, which puts me in the Keytruda category, possibly, for my lymph syndrome. So I'll probably try to contact Dr. Van Allen again and see if I can email him this Caris report. And some of it's overwhelming to me. I don't quite understand it. And essentially, it picks up on both the Lynch syndrome and the BRCA mutation, and it targets both Keytruda and the olaparib. So I've done a little bit of reading. I'm not gung ho to get into Keytruda right now. It doesn't seem like my cancer is going gangbusters. I mean, I don't have my PSA is around 2.4 or something like that. 0.24. So it's not undetectable. I'm still on Nubeca. So it's taken it down, but it hasn't taken it to undetectable yet. I'll do another blood test next Monday, a week from today. So I'm kind of in a holding pattern. I'll see if I can get an appointment going next month with Dr. Turner and kind of talk this through with him. I don't think the local guy is going to really have much of a vote, because I don't think he's got experience with this, but it feels somewhat under control and okay. I've still got some odd side effects from the chemo. Whatever, neuropathy in my feet, I can remember, that's not that terrible. It's not driving me nuts. The thing that is kind of weird is, I don't know if anybody's ever had it, is excessive tearing, which seems to be a side effect of docetaxel for me, a reaction to docetaxel. It started about a month ago, and I'm just crying all the time, and it's not because I'm on hormone therapy. It's my eyes are just tearing up, and when I'm driving, it's like looking through a rainstorm. I've just constantly got tears in my eyes when I'm reading, when I'm driving. And it's a little bit annoying, and it's actually a safety issue when I'm driving, particularly at night, because it affects my vision. So I'll probably let me try to make an appointment with an eye doctor for next week and see what they say. But everything I've read seems to say that some people have a reaction, not everybody, to docetaxel.
What does say about it, Peter? Have you not? I mean, that's the first stop.
I didn't hear you.
What does your medical oncologist say about the tearing?
I haven't gotten to that yet. I have an appointment with Wednesday with a local guy, and I haven't talked to Turner about it yet.
That's the first stop. Talk to the local guy about the tearing. He gives docetaxel to many people. He may know there may be something he can give you, some drops, something to help. Before you start saying, I've got to see an eye doctor. No, the first stop, docetaxel, chemotherapy, oncologist. If he can't help you, he'll refer you to the eye doc. That's your first stop.
Okay.
It's in the side effects list for docetaxel.
There are many side effects.
Right.
Chemo. It's too many to list.
That's my point, that, when you have these side effects, the first person to talk about it with is the oncologist, because they're specialists in internal medicine. And so you start with him. I first want to say I'm really pleased that you're starting to recover. We all are. That's great news. And that you're feeling strong enough to do some plumbing again. That's always a good sign.
I'm pretty weak. I'm dragging my butt around constantly. I'm hoping it comes back. I don't know. We'll see.
But you've got to give yourself, you're only 3 weeks out. You're not giving yourself any slack here. And you're already talking about, well, I'm okay with waiting a little bit. Hang on. You now have two options. You've got olaparib. So we confirm your the FMI results, and you now have pembrolizumab if you need it, or something similar, an anti-PD-1, PD-L1 drug, but you don't have to dive into it right away. Give yourself a few months to get stronger. Your PSA is 0.24, for goodness sake. It's never going to get down to undetectable because, unfortunately, there's too much going on. It's not a realistic expectation. We'd love to see you get there. Yes, it can happen like it did with Carl, and maybe it will if you went on the olaparib, but it's not realistic to expect that. It's realistic to knock it down to where it is and give yourself some slack and allow your body to recover before you charge into another treatment. Len, do you want to follow up on that?
Yeah, I'm not planning on going into another treatment right away. I'm just reporting on the results. But you're
also talking about, well, I don't know whether I don't want to start this just yet. I want to see, but it's in your mind. We can hear you.
Well, not really. It's not in my mind. I just wanted to see what the side effects are. And Keytruda is pretty scary stuff.
I agree.
Read up on it. Yeah.
Yeah, I agree completely with everything Rick said. Regarding the tearing from docetaxel, yeah, certainly you go to the medical oncologist first. Maybe even go to Turner instead of your local guy, since Turner probably has more experience with that. And I would get busy, Peter, if you haven't already, try different meds for the neuropathy. Try and get on top of that as soon as you can. There's probably at least 3 or 4 different meds that people take. If one doesn't work for you, try another one. But are you taking anything right now for that?
No, it doesn't bother me particularly. Just, it feels like my feet are calloused. I mean, I'm not irritated by it. I can function. I can stand. I can walk. I can do everything. I can chew gum and at the same time, and it doesn't. It's not a big deal. But I don't know if I'm not keen on taking drugs because I don't know if it gets rid of neuropathy. It might make it more tolerable, and mine is very tolerable.
Okay, fine. I guess I misheard you. I thought you said that the neuropathy was driving you crazy. Maybe you said it's not.
No. My eye thing makes me crazy. It's a thing. It's a safety issue when I'm driving. I'm just, and it's annoying when I'm reading because I'm just kind of looking through a windshield when it's raining.
Yeah. That is dangerous. I agree.
Yeah.
So I just put in the chat window right now, or I'm about to, a link for a bunch of neuropathy meds and supplements that you might want to, those of you who are on the call can open it up, and you can see whether, Peter, you can look and see if there's anything that's helpful. I'm just having trouble. Yeah. Okay, there we go. All right, so I just put it in the chat window. So click on that, take a look. Peter, we're going to keep moving along, but basically that's all good results. And I'd love to hear what Turner says about the CT scan and whether he thinks that it's been successful in treating the lesions.
Do you think I should bother Ellie again with this thing, or not send it to him with the Caris report?
Well, I mean, there isn't anything in there that's new, really. Oh, well, the MSI high. Yeah, you could send it to him and say, I just got this report, and could you, I'd like to update my records with it. He'd be grateful for that.
Okay.
From that standpoint, and then, if you have any comments, let me know, but I'm sending it to you to update my records for the metastatic prostate cancer project.
Great. Okay.
Yeah, I think he'd appreciate that. All right, let's go to Ross. Ross, what's up?
Well, hello.
Hello.
I think the last time I was here was a couple of weeks ago. I didn't really say anything. First time I was here was probably a month or maybe 6 weeks ago. And at that time I was I've been diagnosed with prostate cancer with at that time 3+4 7. Y'all suggested I have my doc send a sample to Johns Hopkins, which they did, and it came back as 7, but it came back a 4+3, 7. Okay. So in the meantime, I've had a kind of a wide range of PSAs, and I wanted to get y'all's take on it. They range from 9.5 down to 6.2 to 7.3, I believe, if I remember correctly. All within the space of about, as it happens, about 6 weeks. And I also have a radical prostatectomy scheduled for the 30th of this month. And it's going to have, I'm in Austin right now. I'm going to go to Dallas for that. And the surgeon there is a guy that's done about 1,200 of these robotic prostatectomies. So I feel very confident in him. And I've been doing other things to prepare for this. Lots of physical therapies. I've been doing hypnosis with a therapist who's skilled with surgical preoperative suggestions and postoperative suggestion. And at the same time, I'm not feeling skeptical about getting the prostatectomy, but I'm curious about this range of PSAs. Now, Monday, I'm going to Dallas or I have to get a COVID test on Monday. And so I'm going to go to Dallas for that and have another PSA while I'm there. Now, the PSAs were done by 2 different labs or 3 different labs. So one of the 9.5s, I'm going to go back to that lab and have it done. The other, I had 2 of them in the 9s. One of them was here in Austin, one was in Dallas. And then I've had the 7 was done by one of the same labs, and the 6.2 was done by my PCP's doc lab. He's got an in-house lab. So it's just been a wide range, and it's a little confusing, and I'm just wondering if anybody else has had that experience. I mean, I'm thinking, well, you know, if it comes back in Dallas and it's still down, should I ask them to do some more investigation before a surgery? So
I'm trying to recall. I definitely remember talking to you. But I'm trying to recall if it was on this call or if it was on Peter's call. Peter, do you remember? Was it on your call that we talked to Ross?
It was this one. It was this one.
It was this one.
Yep.
And I guess the reason I'm asking is because if you're a 3, what was your original biopsy?
The original biopsy, I've had 2 biopsies. The original was a 3 + 3 = 6. The next one was a 3 + 4 = 7. And then the Johns Hopkins evaluation of that one came back a 4 + 3 = 7.
And what was the highest that your PSA has ever been?
9.54.
Yeah. What puzzles me is we don't usually work with you. We would normally work with you on Peter's call because you're not high risk.
Mm-hmm.
And this call, we only deal with high risk recurrent and advanced disease. And so I'm trying to recall what it was that we got into with you on this call, what pulled you into that category.
Well, I ended up on this call. It was a Monday evening, and I ended up on this call. It was by happenstance. It was the first time I had joined it, and I have been back since.
Yeah.
If I need to be on a different call, I can certainly do that.
Well, here's the reason why. We don't need to subject you listening to issues around men who have failed their first treatment, their early treatments, or who are not going to be having to take hormone therapy to begin with. Peter's call is really more focused on people like yourself who have low intermediate disease and are trying to figure out, should they be doing hormone therapy, should they be doing radiation, when they should get treated, what the issues are. I'm talking about these sorts of fluctuations in PSA. We can talk about it here, but the men who are on this call are long past that point.
Mm-hmm.
The only reason we talk to men who are getting initial treatment is sometimes they're diagnosed de novo metastatic, sometimes they're diagnosed and have to go straight onto hormone therapy, and but none of that fits you. And I'm sort of stretching my mind to recall, because I do remember you, but interestingly enough, I don't have any notes on you. So I was wondering, it could have been a Monday night. Peter is on a Monday night, but he's on the other Monday night to me. So second and fourth Monday nights are Peter, first and third Monday nights are me.
No, I've done the first and third.
Have you? Okay. Well, I mean, let's just ask, let's see if we can answer your question quickly. Anybody have any input as to why the PSA might be fluctuating the way that it is?
I have a comment, Rick. First of all, if I heard Ross correctly, he said that he's gotten 3 PSAs from 3 different labs. Is that
Right.
correct? Yeah. Well, that's the first problem. Even the lab reports themselves say, you know, results are not comparable with any other lab. So settle on one, you know, LabCorp, Quest, whomever, and stick with that. Okay. That way, if there's any fluctuations that are significant, you'll be able to see it. And the second thing is PSA can fluctuate wildly based on time of day, whether you've exercised. You know, there's a lot of factors that can affect it.
Right.
So just bear that in mind in the future and try to stick with one lab.
Yeah, I appreciate that. And the PSA I'm going to have on Monday is the one that I've been getting my PSAs at for the last 3 years. That's the one I'm confident in, actually.
Yeah, definitely stick to the same lab every time if you can.
Okay. Okay. Yeah, it's kind of hard in one part of the state and going to see this doc in another part, but that's certainly doable. And I'll check in on the second and fourth. I'll have at least one. Be able to do it at least once.
Monday night, I just looked you up and I don't have you on for a reminder for this call. I only have you on as a reminder for the low intermediate risk call.
Yeah, well,
But you're welcome. We welcome anybody, but the reason we split the calls is because it can be very intimidating for men to listen to, you know, people who are so advanced. And we don't want to discourage you before you've even put your toe in the water.
Well, I appreciate that.
Okay, but you'll get a reminder for Peter's call next week with Peter's inimitable musings. So open it because they're worth reading.
If I get back from Dallas early enough, I'll check in on it.
Okay.
Hey, Ross, I'm a 4+3 as well, but I'm a recurrent that had my radical prostatectomy about a year and a half ago, and then PSA started to creep. So that's why I'm in this group. But just want to say that, you know, yeah, stay with the one lab and find a great team to stick with, and find a good medical oncologist who specializes in, in prostate cancer.
All right, so we're gonna move along because we've got half an hour left and a bunch of people to visit with. And I want to go to Doug Matthews. Doug, have you any updates since last week? I did put out feelers for you to three of our docs. I haven't heard back from any of them yet, but I wonder if you have any update for us on where you are this week.
So can you hear me okay?
Yes, we hear you fine.
Okay. So I guess the first thing is that Dr. Singh wants to put me on cabazitaxel, and he wanted to do that on the 10th, and insurance held it up until today, and it finally got approved. So I will be starting on that on Wednesday, and have no idea what that's going to be like compared with docetaxel, but I certainly had the docetaxel and went through that, and I certainly had the peripheral neuropathy. In fact, I had peripheral neuropathy before, and I have it worse now than I had it then. I'm also looking at maybe talking to Dr. Turner, but I also had touched base with MD Anderson, and one of the guys that I had previously talked to. I'm just going to have a check-in with him on Monday. But all of them pretty much say same thing. The next course of action is the cabazitaxel. And I am going to get the colors done. I haven't gotten that. I asked Dr. Singh to do it. He was kind of reluctant, so I'm just going to do it myself.
Good
but
job.
I have a comparison between that and the tumor results. I talked with I was dealing with Consumer Medical, which is a second opinion house that my company purchases, and they had sent it to the City of Hope, and that was the report that I had provided you before. When he read that report relative to the Caris and all of the MSD1 or H1s and 6s, and I don't even remember what they were all called. But he did say that we were reading that wrong, and that the positives was actually, it's a negative stain, so it should have been negative if it was actually indicating those particular factors. I also talked to Dr. Singh about the.
Well, hold on one second. I think it would be really helpful if you could get your hands on that Caris report.
I agree, and it's like pulling teeth to getting it. Now, they said they were sending it to me in the mail. I'm hoping to see that when I go up to the mailbox on Monday. Mayo was going to give me a copy of it, but I have not seen that yet. So as soon as I do, I'll share that with you. Right now, though, the guy who read it today, who was also involved with the City of Hope, actually passing the information to the City of Hope, basically said all the MLH1, MSH2, MSH6, TMS2 we were talking about is Lynch. In the way that they've written that, he said this is a negative stain test, so it should have been negative if it was positive, I guess is what I'm saying. But I don't know anything about that, so I thought, well, it's really important to see that Caris report, just like you asked, Rick. And so I'm still looking to get that.
On that, Doug, is that your family history would truly support that there's some sort of an inherited germline mutation. I mean, the enormous amount of cancer that you've got really suggests that something's going on an inherited basis. And if it isn't Lynch, it could be, if it isn't a Lynch mutation, it might be another mutation. But, you know, and now we have Peter Kafka in our midst, who is an expert at reading Caris reports, since he got his Caris report in the mail today. So I haven't seen the Caris report. We know the Foundation Medicine reports, but if you can get hold of your report, we can help you interpret it.
Right, I'm going to get that, and hopefully by next time we meet, you'll have that to take a look at.
Yeah, Doug, I got mine from Turner's office. It didn't come from Caris. As soon as Turner's office got it, they forwarded a copy to me. So that's a sign of a good medical oncologist. It puts the goods in your hands.
Yeah, and so mine's been reluctant to do the germline test. He kind of again told me that there was nothing in here that I needed to worry about. I talked to him about the CDK4 amplified with what Dr. Van Allen had said, and he didn't have anything to say about that. It seems like he's just going down through his process flow. Okay, process flow was docetaxel, now Zytiga and prednisone, and now, okay, that didn't work, so let's move you over to cabazitaxel. And I'm just not getting the information from Dr. Singh, and I know he's had some good responses here, but he also told me, I don't know if I told you guys this or not, but I had a telephone call with him today. He said, you know, there's two kinds of prostate cancer patients or cancer patients. Those who have faith in what I can do and those who are more technical. And so when they're more technical, I give them the options. And what I found out was that when he said move to cabazitaxel, he felt like it was more important to move on to an experimental drug, but he never told me that. He never said that. And so I don't know anything about experimental drugs. So I said, oh, well, I guess cabazitaxel, I know nothing about the other. And he didn't bring me up to speed on that. But this week he's saying, well, you know, I have two kinds of customers. I mean, two kinds of cancer patients. I have those that give complete faith to me, and those that I have to give them the options. And I thought you were the ones that needed the options. And I'm thinking, dude, I know nothing about this, and you're just making assumptions like that. You know, it's like, I don't know if I've got the right doctor or not. All I know is I'm headed down another chemo.
Let me just say this. Why don't you, I think you've got to ask him what the options are at this point. Cabazitaxel is one option. What are the other options?
Yeah, so he says the only other option is this experimental program that he had, but that slot is gone and I can't get in it now.
Okay, can you find out what the drug was?
I can try.
Okay, I mean,
he's not very open about what he's doing. You know, it's kind of like it's my special recipe. I don't know, but
I just ask him what the trial number was, and we can take it from there. Ask him what the NCT number was, the clinical trial number, and we can tell you. And in the meantime, yeah, start the cabazitaxel. It doesn't have as heavy a side effect profile as the docetaxel, which I know, right? But at the same time, you know, let's see what we can do for you in terms of trying to follow through. But I don't know. The chemistry doesn't seem to be there. I don't know what to say. I do think that if we can get you some second opinion, some at least some telehealth appointments with some of these really strong medical oncologists in other parts of the country, it might throw some light on this. But I think we should personally start with, you got to get that Caris report. They has to give it to you, number one, and number two, find out what it was that he wanted to give you.
Okay.
Because
maybe I've already started working on the Caris report. I just need to get the NCT number from him then.
Yeah, NCT, T as in Tommy. Okay.
Right.
All right. Anybody else want to talk to Doug this week? Yeah, go ahead, Herb. You're muted.
I think so far it seems like you're on the right track, but it would be nice to know if he really thought you had options, what they were. Because otherwise it's sort of hard to say where we are. And then I agree, a second opinion with somebody else at this stage, I think would be important.
Okay, I appreciate that.
Hey, Doug, just wondering if you reached out to Dr. John Mulhall at MSK.
No, I didn't. And one of the reasons that I didn't was, well, A, he's in New York, but B, he was a urologist as opposed to a genitourologist, which was, you guys had been pushing me one way. So I had kind of talked that, I don't know.
Well, I mean, a urologist, that's GU, right? they're all GU, genitourinary. But he treats all kinds of patients with problems with the penis. I'm sure more than anybody else in the U.S., I wouldn't be surprised if he knew more about penile cancer or metastasis to the penis than any other doc.
Okay.
I think it's right. You don't have to go to New York, just a telehealth appointment, you know.
Yeah, but I looked at the telehealth for Dr. Jeffrey Hunter, and it's $1,200 cash, which I can do. I mean, I could do that, and I want to make sure I only go to one of these guys because I can't afford everybody.
Right. So you're talking about for Jeffrey Turner, right?
Yes. Yeah.
Not Hunter. You know, Jeff Turner is Peter's doctor, but he doesn't have the experience with penile mets. So I wouldn't spend my money on him because he's not going to tell you anything that the other guys are.
I'm glad you brought that up because here's what Singh told me about that. He said, whether it's in your penis or whether it's in your vertebrae or whether it's in your lungs or whether it's in your liver, it's prostate cancer. and it makes no difference about how the treatment goes.
I would disagree with him because prostate cancer is incredibly heterogeneous. And so depending on where it shows up can indicate what type of prostate cancer it is. And prostate cancer that you see in the soft tissues doesn't always respond the same way as prostate cancer that is in the bone. And I would not necessarily agree. I mean, yes, it can be true, but it isn't necessarily true. And there are indicators. And for me, if a man has prostate cancer, if they see prostate cancer in his femur or his hip when he's diagnosed, it has a different prognosis than if they see it in his penis. And I would say to Dr. Singh, if it's in my hip, what sort of prognosis do I have? Is that prognosis different to if you see it in my penis? Evidently it is. I don't know why, but it is. So it means the prostate cancer has to be different. And I think that's it's not an answer that would satisfy me. I want to be respectful of the people on this call who see Dr. Singh, but at the same time, I think there is a difference. And so if it were me, and as far as I don't disagree with Len that Mulhall has experience with what issues around the penis, but this is metastasis to the penis. So to me, it is a medical oncologist issue rather than a urologist issue. I mean, my guess is that if Mulhall found metastasis to the penis, he'd probably refer it to a medical oncologist and not treat it himself. I'm just guessing.
Oh, yeah, I wasn't implying that Mulhall should treat Doug, simply that he might know who to refer him to, or he might say, I've seen this 5 times before, and this worked, or that worked, or nothing worked, that sort of thing. But yeah, of course, he would refer you to a medical oncologist, and maybe one who's treated Mets to the penis before. That was my point.
Maybe you can do that in writing. Just tell him you're looking for a medical oncologist who has experience with penile Mets. Who does he recommend?
Okay. Now, when you say in writing, are you talking about email? Would he even listen to anything?
I would say email. I don't have a line to Mulhall, unfortunately.
Yeah.
There are a couple of people we can reach out to at Memorial Sloan Kettering, but he's not one of them.
Okay. Well, yeah, it seems like I have to make an appointment with them and provide all of the information to all of those to be able to talk to them in detail.
Some of them will respond, some of them will not. Len, why don't you drop Dana Rathcott a line and ask her if Mulhall or she or anybody at MSK has experience with that. I did that for Doug to Dan George, Chuck Ryan, and Paul Korn.
Yeah, sure, be happy to.
Okay, let us see if we can dig anything up for you.
All right, thank you. I appreciate that because I got almost have too much information coming in, and it's and then there's Dr. Singh who has his way.
Okay, well, yeah. I can't address Dr. Singh, but start with the cabazitaxel. Let's see if it responds. In the meantime, we'll keep looking.
Yep, and I will too, and I'll get my second sources going.
Okay, so I've got to move on. I've got to move on.
No problem. Thank you.
Pleasure. Madhav, what's up? Give us an update.
Yeah, thanks. So, basically met with Zarita today at MD Anderson.
Hold on, Madhav. Would you please mute the background from you? Thank you. Go ahead, Madhav.
Yeah, so I met with Zurita today, basically to get the explanation of 0.2 in June going to 0.6 last week. So, the fact that that acceleration was there. You gave me 3 steps, Len and Carl and Peter jumped in as well with some, with some ideas. So bottom line is this, he senses now that, if there is growth, it's probably beyond the pelvic bed, which was where they had radiated post my operation, about a year ago. So he thinks, so I said, where could it be? And his first thought was bone. But obviously he doesn't know. So, we'll have to do a check. So the PSMA clinical trial we talked about last week is what he wants to put me on to. We were talking about thresholds. He said the threshold that he's heard about that is 0.2. So he thinks I will be eligible for that trial. But it is a diagnostic trial. It's basically a trial with the PSMA test to identify, if possible, where it has spread to. If it shows up, it may or may not. And he also talked about a treatment plan. Which was your second step, which was, get onto ADT again. So this time he's talking about 2 drugs. Instead of Lupron, he brought up Firmagon. And he basically, recommended that, saying, look, that's a much quicker start. So a lot of what I heard earlier in the call kind of, already answered a number of questions for me on that. He said it's far more painful and stuff like that. But bottom line, I'll start you off with Firmagon and Zytiga. And after a month or maybe 2, he's going to move him back to Luprons, because by then the testosterone should have come lower and he doesn't need to continue me on Firmagon.
Right.
I also asked him how long I would be on this in all likelihood. And, he said 6 to 9 months and I can give you a break. And why do you want to give me a break? Clearly I took a break the last time and guess what, in 6 months it's come back on. He said, frankly, if you're fine in continuing longer, I would be fine in continuing longer. So I said, I've dealt with, a combination of 3 drugs before, and for the most it was okay. And I'd rather make sure we keep this snuffed out. So I don't mind continuing longer. One other treatment point he talked about, and then I'll have a few questions. But he said, depending on what the diagnostic PSMA scan shows, if there is cancer that is pinpointed, then he may talk about focal radiation as an alternative therapy as well, or as an additional therapy as well. If we can't find it, then we just be on hormone therapy, but otherwise he would go on to that. So let me pause there, because there are a few other things I want to bring up, but I actually this.
Okay, so as we were really talking last week about Firmagon, Lupron, Eligard, Zoladex, were just that you get onto an LHRH drug, ADT drug quickly. I think the plan of Firmagon and Zytiga is probably right on. That would be the protocol for somebody like yourself who doesn't have a large volume of mets, so it makes perfect sense to me. What doesn't make sense to me is that most men we see who consider going on to intermittent do at least 18 months up front. If they can bear it, if they can tolerate it, then you start off with 18 months, even 2 years, and then start about, talk to Jim Ward about that. He wanted to come off as soon as he got on. But we said to him, no, you can't do intermittent just yet. And if there's one thing that I don't understand with Zurita, it's why he took you off after 6 months. Didn't make sense to me and to others who are on this call. So get yourself back onto it. It's not pleasant. You got to do it. But the future could be some long breaks. Like Len will tell you about the breaks he's had off of intermittent. Len, your thoughts?
Yeah, the first intermittent break I had was only 7 months because I hadn't had any primary treatment other than ADT itself. So, and I was a Gleason 9. So I was 49, diagnosed PSA. and treatment brought it down to 0.2. I went on drug holiday, and in 7 months it was at 10.9. However, the second drug holiday I had was after I had radiation therapy, and the PSA went down to, it was 0.4 before radiation, and then 0.1 after radiation. And then I went on what amounted to a 28-month drug holiday before I had to go back on. So that's a nice long stretch, over 2 years.
How long were you on that second time, Len? How many months did you do when you went back on the ADT?
When I went back on ADT?
Yeah, around the radiation.
Oh, well, I'm an unusual case. Most of my ADT was prior to the radiation. Like I had probably 15 months of ADT before the radiation, and then after the radiation continued another 6 months. So it was about 21 months.
Right, that's what I'm asking. So
Yeah.
you were on for about 21 months for that session, right?
Yeah.
Yeah. Anybody else want to input on this IHT issue? What else have you got there, Mr. Mohan?
See, one of the things that I'm sensing, and this happened last year as well, is, they're far more, there's far more experience in treating older patients. I do want a second opinion. We're trying to identify some doctors, but I want to ask you folks, do you know, medical oncologists who treat, I'm 50 now, right? So I'd rather see somebody who's seen that aggression at the younger age, because I feel that very often these guys are defaulting to a bare minimum and then let's see what happens. Right now, there's something that I want a second opinion.
Okay, so I'll give you my view and then you can talk to some of the other guys. My view is this: I don't think it has anything to do with the institution. I think it has to do with the experience of the oncologist.
That's my point. So I'm asking for specific docs who deal with younger patients.
Right, and I think that you're not with the oncologist that I would be seeing if I was at MD Anderson. I'd be seeing Paul Korn, Logothetis, Elena Efstathiou. I think those are people. This guy is young and he's inexperienced. And I think that's the issue. I think that any experienced guy who's been doing this for years has seen plenty of young guys. I don't think there's any different way to treat a younger man. I think the problem with the younger men is oftentimes that they get hit harder with the side effects of ADT than the older men. And so that becomes a big issue. And so you want people that are going to be sensitive to that. I think your issue is you didn't get stuck with the right guy at MD Anderson.
I didn't choose him. He was just assigned to me. I had no idea who was who. So he just got.
I realize. But now, now you're savvy. And, it's a big issue when somebody assigns you a doctor. You got to do your homework on the doctor and make sure that you're happy with that doctor. And I just don't think he's the right guy. I think if we got you if you want to go further afield from where you are, I'd go to see Dan George. I'd go see Dan George at Duke. I mean, that's probably the closest. There's nobody great at Emory. So, I'm thinking I'm moving north from Emory and I'm staying on the East Coast. Duke is excellent. They've got some good guys and Dan George is super.
So, I would prefer going further afield because the sensitivity, the doctor's here. I don't want to go and, straight up confront him. So then, and again, don't worry about location. Even if I physically have to go somewhere, I'm fine in traveling anywhere. If you had to pick one person, would that be Dan George, or would there be a better name that pops up?
I would give you a choice, and you would look. What we do is we like to give you a choice, and you can look at them. You can see them in videos. You can see how they come across. But the docs that I would mention would be Dan George, Chuck Ryan, University of Minneapolis. Probably for you, I think Alicia Morgan's would be good because she's young. And she's very sensitive to the side effect issues.
Where is she?
Northwestern. I would say Chris Sweeney at Dana Farber.
Dana Farber is great, by the way. And Sweeney, Roberts, good.
Hold on a minute, Russ. Hold on. I'll open it up in a second. Dana Farber, MS Memorial Sloan Kettering, it's a toughie. Mike Morris is really good, but you can never get an appointment with him. The same with the guy, I even forget his name because I never talk about him anymore. The guy who's the guy who's the head of the department there? Howard Scher. Very good, but you can never get an appointment with him. So, Dana
I went to his wedding.
Who was that?
I went to his wedding.
Okay. I've talked to him. He's a good guy, but you can never get an appointment. Dana Rathkopf is very good. I don't know. If it were me personally, I probably, Dan George is, and Paul Korn, who we love. We love Paul Korn, but he's not on the book. He's not available to you because he's at MD Anderson. Dan George is as good as they get. He's really good. Len, who would you suggest?
I like Dan George a lot. The only other person, which I don't believe you mentioned, was Antanakis at Johns Hopkins.
Yeah, another great suggestion. Antanakis at Johns Hopkins. Great suggestion.
So I just cold call these guys, or do I need a reference?
Most of the time, you can call them and say, "I am being treated. I'd like to come in and talk to you. I need a second opinion." Yeah. And then if you want to switch your care to them, you switch your care to them. You can do that, But I would start with the second opinion.
Absolutely, that's where I was going with this as well.
So, if you want to go see Dan George or tell us. We can always try and if you have a problem, we can stick something in round the back. We can try and come in round the back. But if you can't get an appointment, but start on your own.
Okay, got it. I will do that. I know we have less time. I just have one final question. The time to start they've given me, so because the trial is just about kicking off, he said it's kicking off next week. I'm going to wait 2 weeks effectively. And obviously they want to do the scan before they start any medication. I was just a little worried because it was 0.4 the previous week. It was 0.6 the last week. I don't know if it's material, but I just wanted to start right away. I don't know what that means, but I just want to ask you.
Well, the only thing I say to you is this. 0.2 is a pretty low threshold for a PSMA. It's visible, but it's not as good. The sweet spot for the PSMA, do you know if it's with gallium or 18F, DCSS, DCFPYL? Do you know what the agent is, the radiation agent that they're using?
Didn't ask.
So always get the trial number so you can look at the trial yourself and ask him for the trial number. The PSMA scan is a great scan. Len, your level right now is you're at 0.6, right? Yep. So you're right there where you should get to see something. If you started, would you wait or would you start, Len? If it were you, would you wait on an ADT or would you start ADT?
Oh, if you're going to have a PSMA scan, they don't want you on ADT.
Exactly.
Right. Okay, so there's, you have to wait.
Yeah.
Okay. All right. One other question. Sorry, there was one final one. You asked me if I was 45.
Hold it for next time. It's already 3 minutes after, and I got a visit with Herb.
No worries. Thanks.
All right. Go ahead, Herb.
So I mean, I don't have anything to report except we had a miscommunication about an appointment because NIH had been shut down. And so I was going to have my PSA measured today. And then my wife said to me, wait a minute, you did your stationary bicycle this morning. And so I wanted to know the group's sense of if anybody has ever known whether that screws it up. So I ended up not going for my blood test today. And the question is, how long to wait?
Well, it's so funny because we never talk about PSA and measuring PSA, and this is the second time it comes up in this call today, of all things. It's very strange. And you have, as I recall, you were diagnosed de novo metastatic, and you still have a prostate, right?
That's right, and that's the other question I've been hammering at them, is I really would like to get rid of my prostate. And there's some, they keep hemming and hawing, saying, well, we can send you over to the radiation oncologist. But I am thinking I really would rather have, even though I know it's pretty miserable, an RT. And I wanted to hear the group's opinion.
Well, a couple of things. First of all, there's no question that, spending half an hour to an hour in the saddle is supposedly going to affect your PSA. They tell you certain things you should not do before a PSA test, like riding a bicycle or sex. I think those are the two main ones, okay? So yeah, it could affect. They say 48 hours.
Huh, okay.
48 hours, you wait 48 hours. Is that right? I mean, which of...
Well, my MO basically says, let's do it tomorrow.
I've always heard 48 hours. And I'm going back to the days when I first started doing this and thinking about the guys that, were diagnosed and that's what I heard. Anybody have any input on this? So these guys are, none of these guys have prostates. That's the problem. Or they've all been
Right.
radiated.
Well, the question is, do I mean, I don't think there's any doubt that I should get rid of mine one way or the other.
Okay,
and
so
which
right. So that's another issue. And I think most of us on here, and I'll throw it open, would agree with you. Most of the guys on here, if they had a prostate and they're metastatic, have had them treated. In most instances by radiation, but somebody like Carl, who's still with us, Carl was in a clinical trial at the outset where he had his prostate removed, right, Carl?
That's correct. I was on a standard of care for several months. I started the trial in July of 2018, and in November I had the robotic surgery.
And that was part of a clinical trial, and we tried to convince him that he might be better off with radiation, but we certainly never opposed them treating the prostate. So we do think from what we see that men who get their prostate treated do quite well. And a lot of these men have been metastatic for some time. Not everybody here, but there's a lot of guys that fall into that category.
So
Yes.
what I'm hearing though is radiation is probably okay.
Yeah, David, go ahead.
If I could redo it, which is great for you, Herbert, if I could redo it, I would not have a prostatectomy. I'd go right to radiation. It's a lot easier. You'll have all sorts of side effects that if you do the prostatectomy, and it's just much easier to go right to radiation at this stage.
You know, so
I mean, just
that's
keep in
what they were-
mind,
that-
just keep
that
in
they were
mind that
pushing
once you have radiation, it becomes that much harder to have the surgery as opposed to the other way around.
Right, you can't.
yeah,
Correct. That I know.
but to me, that's a red herring.
Right.
I mean, you know, when you've got metastatic cancer, it's not that might be an issue if you didn't start off metastatic, but once you're metastatic, you're not going to go, once you've blasted that prostate, you're not going to want to go in and take it out for any reason. You're already on systemic treatment.
Right.
So I think it could be an issue. I hear Carl, but I don't think that's a relevant issue for somebody who's metastatic personally. And frankly, it's not the issue that it was, because now there are plenty of urologists who will do a salvage prostatectomy, whereas years ago there were very few that would do them. But I don't think it's a relevant issue to a man who's metastatic, to be honest. I think your choice is, do I want to deal with my prostate with radiation, or I want to deal with it with surgery? Len, what's your thinking? We had to bang on Len for years to get him to treat his prostate. It took us.
Well, the trials are clear. The people who have done something do better overall. So I knew that's what I want to do. It's just a matter of how to do it.
So the question to me, Rick, was,
I mean, do you agree that if it were you, would you get, and you were diagnosed de novo metastatic, which you pretty much were to your lymph nodes, would you get your prostate treated?
yeah, I would do the same thing I did, which is have radiation rather than surgery. I know quite a number of guys who, just like we just heard from David, that regret having had the prostatectomy because of the side effects. And typically they have to have radiation anyway. I think most often when radiation fails to completely eradicate the cancer, it's because of metastases outside of the prostate. So it's not even an issue like, well, let's go back in and now remove your prostate, because it's usually not an issue. It's not a problem. Radiation, with the techniques they have today, completely ablates the prostate itself. So, like, I agree with you, Rick. It's basically a red herring. It's
All right.
No, also I want to say that I had several scans, and it wasn't until after I had the surgery that they told me I had 2 out of 27 lymph nodes that were positive, and that there was seminal vesicle intrusion. So if it wasn't for, in my opinion, I could be wrong, but if it wasn't for the surgery, I wouldn't have known that I had that.
No, because the radiation, especially you with a Gleason 10, if they said, let's do radiation, they would have hit everything. They would have hit your seminal vesicles, your entire pelvic region, and the prostate. No question about it.
Right. Right. They would have treated all of that, Carl. But I do think you've got to bang on NIH
unfortunately, they've slowed down stuff like this because of COVID. The patient population and census is just being rigid because they don't want to take any chances.
So I think the big issue for you is the type of radiation, and probably to see if you can get them to treat the gland with SBRT, and if they are going to do, maybe you'll come back on next week or the week after and talk to some of the guys. Some of the guys have gotten the pelvic girdle treated, and some have not. If it were me, I would get the pelvic girdle treated, but some of them, even though they're metastatic and even though they've been through chemo, they've only had the gland radiated. If you were to get the whole pelvic girdle radiated, that's usually done with IMRT or IGRT or something like that. But it can be done also with SBRT now. With small, I don't know how they do it, but there's a way that they do with small fractions. Right. So you can do, you don't have to do 15 or 20 visits for
right.
For that.
No, they do this hyperfractionated regimen, which cuts it down a lot.
Yeah. All right. Have we satisfied Mr. Geller? Mr. Geller, you know, we're very impressed now that you're at Howard Scher's wedding. I mean, that makes you a VIP on this call.
Right. Well, my wife was head of statistics at Memorial.
Ah, okay.
At the time.
Okay.
Okay. So that's where our connections are.
I see. Okay.
Now we know who the real Moffat is.
That's right. That's right. The GM, the Ganzemacher, the GM, right? Okay. Anybody else have anything they want to raise? We're 15 minutes over. We can lay that on our friend Bob, because I wasn't expecting any new men. Anything else? All right. So next week, Tuesday, earlier in the day, be there or be square. I wish everybody a very good week, and we'll see you then.
Thank you, man.
Ciao.
Thank you, Rick. Thank you, Dan.
Thank you.
Good night, everybody.
Good night.
Good night.
Good night. Good night.